Hello, everyone. We are live. Welcome. Today, we are going to be going over question and answering. I know we had a live impromptu a couple of weeks ago, or no, that was last week, last Thursday evening, and that was an interview format. That was the first time we did that with microbiologist Karan Krishnan. So if you missed that, you should be able to see that in the live playlist here on the channel. So today we're going to be doing our routine live where I answer your questions regarding mental health treatments, and those types of things. So please go ahead and drop your questions into the chat. Now, we do have priority questions from members. So if you're a channel member, you do get priority answers to your questions. And then super chats are second. And then we just go in order as the questions come in. Now, I start at 11 a.m. Eastern Standard Time and go till 1 p.m. Eastern Standard Time. So that's 2 hours. So just so you know that as well. And I will try and give you a reminder of that as we get closer to the end, in case you have some questions you want answered, just so you know the time frame. Okay, so Raul is working in the background for me, and he's going to be pulling up my questions. He's my moderator. So let's see if we have any here into the comments we can start answering. Okay, here we go. Dr. Sergio Valdez, olanzapine and weight gain with what's the pharmacological basis? Well, olanzapine is an antipsychotic, and one of the primary mechanisms of action and how it creates this weight gain is by blocking histamine. That's one of the ways. Histamine controls our appetite. And when we block it, it can actually cause an increase in appetite. So increasing appetite is one of the mechanisms. Also, hormonal changes with your GLP-1 signaling and leptin and ghrelin. So these are hunger and satiety hormones. Olanzapine and other antipsychotics are known to affect that system. So that is another way that it can cause weight gain. There's also the metabolic syndrome aspect of olanzapine, which in time with chronicity of use can lead to insulin resistance, which can also lead to weight gain. Now, from my understanding of it, the complete mechanism of that is not 100% known. I believe there is some research or some identifiers as far as looking into the receptors on the lipid, different genes that code for lipid metabolism, and perhaps olanzapine can be disruptive in that way and cause the increase in your lipids that we see with metabolic syndrome. Also, we do know that when we increase serotonin too much in the gut, because of course, serotonin is produced primarily, the majority of it in the gut, and then you have a smaller percent produced in the brain. So when you produce too much serotonin in the gut, that can actually disrupt the microbiome and lead to dysbiosis and inflammation. So that in of itself can lead to insulin resistance as well as weight gain, just by the disruption of the balance of the beneficial bacteria to the bacteria that is not beneficial for us. So that is another way, and can lead to increased permeability or something called leaky gut. I do have a video about the gut-brain connection if you're interested in that topic, but that is another mechanism that has been looked into. And those are the ones that I know primarily just from the top of my mind. I'm sure if you dig in a little deeper, maybe do a Google search, you might find other mechanisms, but those are the ones that I'm more familiar with. Ways to help mitigate the weight gain from olanzapine is going to be, of course, exercise and diet, watching what you're eating, because of course, increasing appetite is one of those primary mechanisms. So what I always tell my patients is, to keep food available that is going to be low calorie, low impact. So when you start craving carbohydrates and sweets, you have fruits and vegetables as snacks in your pantry, in your refrigerator, so you're not tempted to reach for the other higher calorie snacks, like candies and chips and things of that nature. So, a very good question. So, thank you for that. And we'll move on to the next one. Dr. Sergio Valdez, hello. Are nightly nightmares considered a form of psychosis? Thanks. Okay, so nightmares would not be considered psychosis. It could be a form of anxiety, insomnia, or PTSD. That's what I first think of when I hear nightmares, especially nightly nightmares. Maybe there's some unresolved trauma there. Now, if you're talking about nightmares, like when you're waking up and you're still hallucinating, that would be hypnopompic, which is a type of hallucination that happens when you wake up and you're still in like a dreamlike state, and you're still having like visual hallucinations of the dream. Some people may hear things as well during that time, but it's short lived. There's another one called hypnagogic, which is when you're falling asleep, and you start to have some hallucination or type, and then you go into your dream state. That would not be considered psychosis. Those would be termed, if someone was mentioning that to me, I would document it as a hypnopompic or hypnagogic hallucination. So it's just related to the sleep state, whether you're falling asleep or waking up. Now, if you started having these hallucinations outside of a dream state, then that would be then termed psychosis. But just recurring nightly nightmares, I would dig deeper into why the person is having these nightmares. Is it trauma induced? Is it fear based? Is it anxiety induced? Those types of things, and look at that aspect of it. Thank you for the question. Okay, Dr. Sergio again. Okay, wonderful. Does olanzapine help with chronic musculoskeletal pain? Not to my knowledge. When I think about olanzapine, I certainly don't think of treating chronic musculoskeletal pain with it. Its primary use is for schizophrenia, bipolar, and then treatment-resistant depression. So those are the top three uses that you would see it used for. It can also be used in patients with anorexia to help improve their appetite as well. So those are like the main reasons, and chronic musculoskeletal pain is not one. When I think chronic musculoskeletal pain with depression, I'm thinking maybe SNRIs like Cymbalta, or tricyclics, like amitriptyline or something of that nature. Does duloxetine help with chronic muscular? So yes, that duloxetine is Cymbalta, and that medication is an SNRI, so it's a serotonin norepinephrine reuptake inhibitor, and does have studies that back up its use in like fibromyalgia. So patients who have fibromyalgia, which is more of a muscular nervous system pain rather than musculoskeletal, but has been shown to help in reducing that. Now, I have patients who are on Cymbalta who have chronic back pain, or sciatica kind of pain, so nerve pain, or even paresthesias from neuropathy, and seem to have relief with the duloxetine or Cymbalta. So that can be helpful there. With musculoskeletal pain, so it's more a nerve pain that it's going to help. With musculoskeletal pain, it may help some, especially if the nerves are involved. Now, with musculoskeletal pain, maybe muscle relaxers may be more beneficial to help. I guess it depends on the source of the pain, and why the person is having pain. You may need to reduce inflammation, for instance, instead of looking at targeting the nerves and trying to calm down overactive nerves. Hello, unknown aspirant. Hello. I am Sheer, why I self hate much and why I don't want to improve myself. Well, hi, Ashir. I appreciate your question. And it sounds like you're doing a lot of self searching here and trying to figure out why you have these impressions of yourself. This your self view comes from many different aspects. So it could be from childhood, it could be from what we are told from teachers, from parents, from friends, from bullies, from coworkers, that could make an impression of us not viewing ourselves as worthy or viewing ourselves as good enough. um, the fact that you want to improve yourself, I think, is great. Therapy would be something, an avenue that you should tap into to help uncover what your reasoning is behind the low self esteem and behind this voice that you have, that is causing you to not like yourself. So definitely look, because there are many aspects of it that could be causing this type of self talk or negative self talk in the mind that happens, that creates this feeling of self hate and loathing, and that can lead to depression, it can lead to anxiety, it could lead to a lot of mental health problems. So definitely recognizing that this is a problem, knowing that you want to improve, is great. That's the first step. And getting into a therapist that works with self-esteem, that works with CBT, that'll help with reframing these negative thoughts, and help build your your self-esteem up, but also like using like things like positive affirmations can be helpful. Mindfulness practices. There's a really good mindfulness practice called acceptance, that goes through like self-love, and I really enjoy that type of mindfulness practice. So and there's a lot of free mindfulness meditation videos on YouTube, actually, where you can find compassion mindfulness videos, self-love mindfulness videos that kind of help you go through this self-compassion, self-love, to really build up and start to help build up your self-esteem and start to um, negate some of those negative thoughts that you're having. But it is common. I want you to know that you're not alone in this. This self-hate, self-loathing, and feeling down about yourself. It happens very commonly, like I said, just for those influences from outside that we get in life, unfortunately. But so we have to work hard to build up our positive mindset, because the negative mindset is really the default. It's easy to go into the negative thinking. Michael asks, hello. What is your opinion on dopamine supersensitivity? Does that make you have the therapeutic tolerance? How do you reverse it? Dopamine supersensitivity, and therapeutic tolerance. So there are people who are more sensitive to the effects of dopamine. I'm not sure that those people lead to tolerance more than those who are not super sensitive. Usually, those who are more super sensitive to dopamine, and the effects of stimulants, if we're talking about like ADHD medications and things like that, are those with a lot of anxiety. Now, if you are someone who is dealing with a lot of dopamine super sensitivity, and you're feeling overstimulated by things like your phone, social media, because they have a lot of things in like reels and clips with noises, and to give you dopamine hits that you may be reacting to and you may be sensitive to. So if that's the case, you want to limit your use of social media, limit your use of those types of devices. And of course, video games can also, some people can be reacting to that as well. A way to help with reducing it would be not only to eliminate the use of those things, but also then do more mindfulness practices, more calming practices to lower your hypersensitivity. So it could be due to, like I said, the anxiety, but that's oftentimes due to what we call HPA dysregulation. So hypothalamic pituitary adrenal, like your fight or flight regulation may be off for various reasons, whether it's stress, whether it's trauma, and those types of things. So working with a therapist could be a really good idea for you to really help to lower the supersensitivity. Now, those who develop a tolerance to overstimulation of dopamine, that is done by repeated dopamine hits, whether it's pharmacological or whether it's external, like what I said, video games and those types of things, with social media, etc. And the solution for that is to limit the use. So with medications, I encourage patients to do drug holidays. So not taking those stimulants on the days that they're off of work or off school, like on the weekends, for instance, or over the summer and things of that nature to help lower the tolerance to dopamine stimulation. So yeah, definitely getting into mindfulness, CBT work would be helpful, lowering your anxiety. Yoga would be good for that too. And breathing, anything to activate the vagus nerve is really going to be helpful so that you're not overreacting to dopamine. Good question. Thank you. Unknown aspirant, hello. Can autism cause depression and ADHD, and which doctor can diagnose me? So, when it comes to autism spectrum disorder, not that it can cause depression or ADHD, but they can be comorbid, meaning they're oftentimes seen together, especially ADHD. So there can be components of having two. So you may have autism and ADHD, or autism and depression, or you may have all three. That is not an uncommon thing. Now, you do want to be able to have a provider. So a psychiatrist or neurologist would be the best to go to, and someone who has an expertise on neurodevelopmental disorders. So that would include ADHD and autism, because they could do specific testing to see where you fall. Maybe there are learning disabilities involved in there as well. So they could help tease that out for you. And then with that, you can then determine whether or not you're dealing with is this just autism spectrum causing some of these symptoms, or is it actually a diagnosis like ADHD, or is there depression there as well? Because the treatments look different. With autism spectrum disorder, you're typically going to be doing a lot of behavioral interventions, social interventions, social integration type interventions, and working with the therapist that specializes in autism to help with some of those symptoms. And then ADHD can be done therapeutically with different skills and CBT and things of that nature as well as medications. And of course, depression can be treated with therapy or medication. Really, no medication to treat autism. As a diagnosis, but if there are symptoms with that autism of these mental health problems, then you would be looking at treating those mental health, symptoms or illnesses with the medication. Okay, Grant Rennie, hello. I could use your expertise to improve my charity volunteering efforts and also to help a close friend. Okay, I'm not sure what you mean by that. As far as your expertise in improving your charity volunteering efforts, if you want to improve your expertise in those areas, I would recommend volunteering, signing up for something that you feel is worth your while. Maybe it's NAMI if you're talking about mental health. Maybe there's a local community or club that helps men or women with mental health problems or addiction problems. There's a lot of ways to improve your charity and volunteering efforts. Maybe just Googling in your area what is available for whatever it is you want to be involved in to help, and then see if they are accepting volunteers, accepting members. That's what I would say to do to help improve in that area. Jenna Jameson, hello. Jenna Jameson Lee. Insulin resistance is common with azenapine, Sapphire's medication. Yeah, it's common with the atypical antipsychotics, unfortunately. Like I was mentioning earlier with the olanzapine, very similar issues with the azenapine as well. And which is also known as Sapphire's. So yeah, unfortunately, all of this, what they call the second generation or atypical antipsychotics, have this insulin resistance as a potential factor. Not as common as olanzapine. I say olanzapine and Seroquel are going to be the top when you're looking at what can lead to insulin resistance, but even something like a centipede, even though it doesn't have as much on the weight gain factor, can still cause insulin resistance. So can those like Vraylar, Latuda, the newer ones that tout weight loss or weight neutral benefits. That's great, but over time can still lead to this insulin resistance, which can be by many of those factors we talked about, with influencing different lipid metabolites, genetics, hormones, and things of that nature, and even increasing too much serotonin, which is where antidepressants can also cause a similar issue with the gut, like I was talking about earlier with leaky gut, gut permeability, with increasing too much serotonin leading to gut inflammation. So those are all factors to consider, unfortunately, with psychotropic medications, especially when you're dealing with serotonin modulation, dopamine modulation, etc. So, which is why I am very conservative with my approach with medications, and prefer to look at root causes of mental health symptoms and treat nutrient deficiencies, any gut imbalances that we may find, or inflammation, or increased stress response, and all of those things, using skills first before going to pills. And if we are using pills, um, using them for short term, and then working on skills to help patients come off of these medications, because long term they can have these effects. Muhammad Faizan, hello, Muhammad. Doc, can I take Tonkat Ally with my antidepressant or antipsychotic they prescribed me for treatment-resistant depression, and want to know, can I take Tonkat Ali? Um, so I'm a psychiatric nurse practitioner first and foremost. I know a lot of people will say, call me doctor, or this, that, and the other, but I just don't ever want to be accused of posing myself as something I'm not. So I want to always, every time someone addresses me as doc or doctor, I want to make that clear. As far as Tonkat Ali, this is a supplement that can increase testosterone, um, can also downstream increase dopamine by increasing testosterone. Can it be taken with your antidepressant or antipsychotic? That would be something to talk with your doctor about, because it depends on the medications you're taking, your dosages, and other variables as well, with what we're trying to achieve. So I would not take it without consulting with your doctor and letting him or her know that this is something that you are considering, and letting them know why you're considering this, because it could have there number one, there could be some interactions with your medication. And you could look up herb drug interactions. I think the RX checker, I think I have that listed in the description as one of those resources. The drug RX checker will allow you to do that, to see if there are any interactions with Tomcat and your medications that you're currently taking. There's also a nutrient interaction checker by Integrative Therapeutics. If that one for drug RX doesn't have Tomcat listed as one of the ones to check for, the nutrient interaction checker may have that. That's from Integrative Therapeutics website, because they have a lot of the supplements that some of these other interaction checkers do not. But so I would kind of look there to see if there's any interactions. Off the top of my head, I cannot say that there would be interactions or not knowing your meds, but also just um, I don't know the mechanism, if there are any CYP metabolism mechanisms of Tomcat. That's something I would need to look into and know to understand if there would be drug interactions. So those are things to look into. But also, like I said, first and foremost, discuss it with your doctor, because they would be able to help you maybe come up with a different treatment option, than the Tomcat, Ali. Okay. Ganesh T, hello. Please make a video on which meditation is most helpful for ADHD and the science behind it and mechanism of it. Yeah, I have one on meditation in general, mindfulness meditation in particular, because that meditation, and mindfulness in general has probably the most research on efficacy in helping with depression and anxiety. Now, for ADHD, it can be helpful. I would have to tap into the research in that, to consider doing a video on that. That is not on my list at this time. I can put it on my list. Now I have member requests come first. I actually am working on a member's video request on tianeptine. I just went through some research on that a member brought to my attention. So that's actually going to be one of the videos I'm coming up with next. Clomipramine is another one. That was a topic that was recommended by several of you. So I kind of look at which topics are being recommended the most, and then look at, of course, my members, my channel members. So that's why that one will be coming up first. And then topics that are of interest, like for instance, inflammation and depression, and the link to that. There have been questions raised about that in comments. So I'm going to be doing a video on that. So this is something that I can put on my list. And if we have more people interested in that, I could certainly make a video of it, but thank you. I did make one that you had recommended about meditation, because that was one I already had up about meditation and how it can help improve mental health symptoms. So that video is already out there, and it didn't do so well. I'm not surprised though, because a lot of the people on the channel want the quick fix medication solutions, and unfortunately, meditation is not a quick fix solution. So that's just how it is, I guess. But thank you for that. Ganesh, how long meditation need to perform per day, and how does it decrease sleep need, and why? Um, okay, so it depends on the type of meditation you're doing, because there's different meditations that you can do to help to improve alertness, awakeness, focus, and attention, like you just said, for ADHD. Those obviously you would be doing during the morning time. It doesn't decrease your sleep need. Um, there are, at least to my knowledge, meditations at night, there are different ones that help with slowing down like that HPA axis, like I was talking about, your body scans, your progressive muscle relaxation, your mindfulness based meditation. So they are going to help really slow your thoughts down. And mindfulness can also help with focus too, because of that. A lot of the lack of focus and concentration has to do with the rumination and the thoughts that are happening in our minds that distract us from staying on task. So therefore, when you do mindfulness meditation over time, usually about 4 weeks, 6 weeks time, you start learning how to basically quiet the noise. And so, because you're able to quiet the noise of these thoughts and not go down the path of the judgmental thinking that usually happens when we start having thoughts that pop in our minds, we want to chase them. With mindfulness, we learn to just let them be and not to judge them and just accept them as they are. And over time, you lessen your reactivity to those thoughts, whatever those thoughts may be. So that is how it helps. Also, because you're lowering the stress response, you're lowering your reactivity to the thoughts, you are then decreasing inflammation, decreasing cortisol, and actually inducing a more relaxed state. So it's not that you decrease your need to sleep. You would actually, especially done at night, help melatonin production, help to induce a more sleep state. When you're doing meditation specifically for focus and attention, there may be some breath work involved. And oftentimes there are some deep breathing techniques that help with more alertness to get more oxygen flowing to the brain. So that could obviously be done during the day. And so you're leveraging that and helping to improve your concentration and focus that way. But to my knowledge, it doesn't decrease your need for sleep. Okay, Nerdmama, hello. We got a super chat. Oh, I don't have my super chat video. I forgot to put that in here. I have to put that in at another time. I forgot to add that to my thing that I pop up. Anyway, thank you so much for the super chat. I really appreciate it. Prestige and Boost Bar are my meds. Switched from Effexor based off test. The MTHFR gene was found during testing. L-methylfolate was suggested. Your thoughts? Good question. So it sounds like you were able to find which medications work better for your genetics based off the gene site test, which is good. Hopefully, these are working well for you. When it comes to the MTHFR gene, I have a video on that, but I want to stress the point that I talk about when it comes to epigenetics. Just because you have a gene doesn't mean you need the treatment for it. Okay. Because that MTHFR gene may be turned on or off. So it might not be a factor. So, how do you evaluate whether or not this is a factor? Check your B12 and folate, make sure those are being optimized. Check your homocysteine. Homocysteine is going to be the most important blood test you could do for someone who's MTHFR positive. Insurances will oftentimes try to not cover this, and it can get costly if you're using like Quest Diagnostic, using an insurance-based lab instead of a more discounted lab. But anyhow, so checking the homocysteine. What you want to tell your provider is please make sure that you put down there is a code, an ICD-10 code for MTHFR. So they would have to put that you are a methyl tetrahydrase reductase, gene, that you have a variant of that gene. I forget what the code is off the top of my head, but they should be able to look that up and make sure they put that code, because that code, because you have this gene diagnosis, should get this gene, this homocysteine covered. Because if homocysteine is elevated, okay, and we're talking about above 10 here. Optimally, I like to see homocysteine between 5 and 7. That's optimal. That's dialed in. If it's above 10, we really need to start looking at ways to reduce homocysteine. And if you know your MTHFR, whether it's TT or CT, it doesn't matter. We know that that's a factor. So then L-methylfolate would be very helpful. Depending on how high the homocysteine is, would depend on not only how much L-methylfolate, but if we need to add in something like trimethylglycine, which is TMG, which will help to bind and convert that homocysteine to cysteine. That's what needs to happen. Another thing I want to mention here that's so important when it comes to L-methylfolate is that not everybody can tolerate L-methylfolate. So in that test, you should also have the COMT. It's not highlighted well in the gene site test. One of the reasons why I don't use that test often, and I prefer GenoMind, but nonetheless, they at least test for it. So if you are met with your COMT, where if it says MET/MET, that means that you are slowly inhibiting your catecholamines and your dopamine, your norepinephrine. So you're someone who's probably going to be more on the anxious and stressed and worried side. Okay. If you then uptick methylation, which is on one side, and we start speeding that up, that gets dumped into that cycle of the catecholamine cycle where S-adenosylmethionine or SAMe is used to help with catecholamine production. If you're already cycling that slowly, so met means that you are cycling it too slow. Val would mean too fast. Val met is where you want to be. Okay. If you are met and we give you methylfolate with that cycle, that could actually increase anxiety. And unfortunately, that is where a lot of people have problems with methylfolate. In that case, you would want to use um, the folinic acid instead. So not folic, folinic acid, or high. I believe it's a hydro folate instead of a methyl folate. Um, from the top of my mind, Seeking Health Nutrients has like the non-methylated forms that are also bioavailable for these patients who are in this zone of having the COMT met and the MTHFR. So that's what you have to look at this as a whole picture. And those genes aren't the only genes you want to be looking at when it comes to methylation as well, which is where a lot of these drug interactions, both GeneSight and GenoMind, aren't looking at lifestyle factor genes and other nutrient genes, because there's beyond MTHFR, there's MTR, MTRR, your other B vitamins. So those need to be taken into consideration as well if they're turned on. So if you're having symptoms and if particularly homocysteine is high, then I would consider going down this path. But if L-methylfolate causes you to be anxious, then I would look at using other forms of folate to help lessen that increase in anxiety. So lots of research that shows people with MTHFR will respond positively to L-methylfolate, especially for treatment-resistant depression or for depression in general. But you just have to be careful with how much you give that person, and that you don't overdo it, because you can over methylate someone and cause anxiety. That's I guess the overall summary on that. But very really good question. I'm glad you asked it, because a lot of people, a lot of practitioners, they see that, oh, I guess you need Deplin, I guess you need Enlight, and they're now giving you medical grade L-methylfolate, which is high dosages. 15 milligrams, sometimes 30 milligrams. I mean, that for some people can throw you off and make you more anxious and not be good, though it can be helpful. So I'm not saying can't. It's just you have to look at it in the whole scope of things. We have to look at your biology, what are your symptoms, and those types of things before jumping to that conclusion. Because like I said, a lot of practitioners do that, and then they actually may cause harm to the patient by increasing anxiety for them and panic. Okay, next question. Can it worsen anxiety? Been more anxious since starting it. Yeah, like I just said, that's what that's exactly what I was talking about. Check your COMT, like I just said, and then see if you need to if your COMT is Valmet and you're fine, or even Val, you could do high dosages of methylfolate. If it's met, you can't. You want to either lower that dose significantly and only give yourself a little bit, or look at the other forms, the non-methylated forms of folic acid. Like I said, Seeking Health is the only one that comes to mind right now that has the non-methylated forms of folate and B12. They have hydroxycobalamin as well, that you could use as instead of. But do you need it at all? Because if you don't need it, like say you did your labs and your B is spot on, your B12 is above 500, your folate's above 15, you're looking good there. Your homocysteine, which is the better marker for folate, is dialed in. It's below 10, and maybe it's even optimal. Then yeah, you're going to end up creating more anxiety that way as well, just because you're now increasing, what the B vitamins do, right? They help with energy production and alertness and those types of things. So that can make you feel more anxious. So you just have to look at it in context. Anthony Kenyanju, hello. Hi, vortioxetine sleep disturbance. Yeah, I've heard of vortioxetine causing for some people nightmares, and sleep disturbances. Hopefully, you're taking it then in the morning. It's not a very common side effect, but I've heard of it happening from people. And so you would want to take it in the morning, and first thing in the morning. If that doesn't help, then perhaps reducing the dose. If you have to reduce the dose and it's not as effective at that reduced dose, then talk to your provider about other solutions. And as you know, or maybe don't know, with me, I'm going to be looking at what else is going on, especially with sleep. I think zinc, I think magnesium, those kinds of things, making sure that we're optimizing your nutrients to help with sleep. So that is those are other factors to consider. So I'm thinking with sleep, omega-3s, vitamin D, zinc, magnesium come to top of mind for sure. For all mental health, those are all very essential nutrients. But specifically with sleep, zinc makes that conversion from serotonin to melatonin, so very, very important. And then there's a limiting step for use of magnesium. And also magnesium is also very important for the stress response. So if you're having high stress, if you're wired and tired and having that high cortisol response at night, magnesium could actually be very, very helpful for you. Magnesium glycinate, more so. So just, keeping those types of things in mind, of course, reviewing this all with your provider. But unfortunately, with all of the antidepressants, sleep disturbance could be a factor. If you really look at side effects of antidepressants as a whole, they all have insomnia or hypersomnolence, right? So it could swing either way. So I've seen it for both. I've seen where it makes you too sleepy. They say take it at night. It makes you too wired. You're not falling asleep. Take it during the day. But obviously, we have to look at these other factors of these mental health symptoms and do your mental health labs. And if you haven't already, looked at that mental health lab video that can help guide you. Okay, next question. True Human, how GABA and gabapentin is different from GABA of benzos. So it's not different. So the benzodiazepines work more directly on the GABA receptors and are more directly inhibiting the GABA system. Okay. And so because of that, they are listed as controlled substances because they are more acting on that system, and that can create tolerance of, unfortunately, abuse and dependence, etc. Now, gabapentin works more indirectly on the GABAergic system. So now, what I do have to say though is that there are some states that do make gabapentin a controlled substance because they have found that patients were able to abuse gabapentin and get this kind of euphoria type of sensation or high, um, by lowering GABA to that point, similar to benzodiazepines, but not in all states. Okay, so But gabapentin is more indirectly the short answer, gabapentin is more indirectly on the GABA system. Benzodiazepines are more directly on the GABA system. When I look at these two medications, I do tend to look both at both of them very similarly, um, because unfortunately, there are patients who try to come off of gabapentin. Another one is pregabalin or Lyrica. Okay, stronger inhibition on GABA, um, and they have trouble coming off. Very similarly, very similar picture to the benzodiazepines. Um, However, I do know that there's research out there, and there are people, that I work with that still, they've been on gabapentin for a long time, and they were put on a benzodiazepine, and they're coming off their benzo. So we're not going to just rip them off of their gabapentin as well, because that's going to throw them into more withdrawal. And also, there are clinics that use gabapentin as a buffer to help someone to come off of benzodiazepines because of those similarities and to help ease the withdrawal symptoms. But in that case, you're just trading one dependency for another, you know. So, one, I guess you could say a lesser evil, when you're looking at the two, maybe gabapentin is the lesser evil. But in my opinion, they're both the same. They both long term can cause problems, both can lead to tolerance and dependence, both can have significant problems when you're trying to come off of them. So I look at both the same. Good question, though. Awayas, hello. My skin type is oily and I've been noticing light brown patches on my face for a few years. My question is it because of cholesterol or liver issue? I had fatty liver issue in the past. It can be. This would have been a great question for Kiran. He did a live with me last week on Thursday. You may have missed it. The replay is there, it's available. He talks about the connection with the skin, our skin microbiome, and all of these different factors, and how it can also affect mental health. Now, liver, so when we have dark spots, it can be from inflammation. It can be from, they call them liver spots, because it can be from liver disease, whether it's fatty liver, alcoholic or non-alcoholic fatty liver disease, or just a liver deficiency. Your liver's not working to its capacity, and you're creating a lot of uh, toxins that way, like toxin buildup. Okay, so that's showing up. The dark spots can also be from hormones. It's another big problem there, or sun. So we've got all these factors that could be contributing to darker spots. But you're saying they're light brown patches on your face. So you definitely, when we're looking at this, want to reduce inflammation, number one. So in your diet, you want to lower your inflammatory burden. So an anti-inflammatory diet would be very helpful, because, just like Karan was saying about, where it's all connected. It's all, the systems are all connected, and our skin is our largest organ. And anything that you're putting into your body is going to either positively affect your skin or negatively affect your skin. So get rid of inflammatory foods, processed, foods, sugar, high sugary foods, simple carbs, those types of things. And look at more of an anti-inflammatory diet. Just Google that. You'll get tons of tips on that. Then when it comes to skin and helping, with your skin, you want to lower your toxic burden on the skin. So limit the amount of products you're using, and limit, your ingredients to minimal ingredients. Get rid of fragrances and those types of things that can be interfering with your skin or causing reactions. And he has a really good product called Siv, S-I-V. You could look at, I believe Siv Care is the website. And if Raul, if you have that website handy, you could put it in the link for Awayas so he can look at that product. Very good for balancing the microbiome of your skin, helping to lower inflammation and lower these types of problems that stem from dysbiosis. When you have inflammation going on and you have problems on the skin, it stems from dysbiosis of your microbiome, your skin microbiome. That's what we then term leaky skin, this permeability of the skin, which then drives inflammation in and of itself. And then you've got your internal inflammation drivers as well, like poor liver function, etc. So, so dealing with that could certainly be a cholesterol liver issue. Work on an anti-inflammatory diet. Drink plenty of water too. That's going to help your liver to flush out toxins and lower your toxic burden. Now, if you're able to urinate well, if you're able to go number two, defecate and everything well, and those things are regulated and you're not holding in toxins, then you could look at things to help support detoxing your liver. Things like milk thistle, dandelion root, herbs, teas that you can start drinking to help support your liver. But I wouldn't do that until your inflammatory load is down, your toxic burden is down, and you're able to go to the bathroom well. Every single day you're having bowel movements. It's not too loose, not constipated. Because if you try to help detox your body when you're not able to excrete the waste, that can lead to increased waste buildup in the body, which is not good and can lead to more inflammation. So yeah, summary, that skin can oftentimes be a factor of what's going on inside, can be coming from liver, could also be inflammation, sun, and hormones. And there are ways to reduce that. Check out the leaky skin interview I did with Karan. He goes into very detail about all this, the connections of all of it. Okay. Well, yes, whenever I get tested for lipid profile, your cholesterol stays high. Okay. Whenever the doctor tries to put me on statin, it makes my irritable bowel syndrome worse. I gain too much weight from olanzapine and Mert. I'm guessing that's mirtazapine in the past. Okay, so your lipid profile, your cholesterol usually stays high. Oh gosh, and statins are usually not the answer. Okay. Sometimes cholesterol is high for genetic reasons. Ways to help naturally reduce cholesterol, fiber. Okay, really important in the diet. Anti-inflammatory diet, great. Again, we're talking about inflammation, high cholesterol, inflammation. But we also don't want to make cholesterol too low. We want to see it 150 to 200. We want to see it, even if you're a little above 200, not too bad. What we really want to dial in on when it's bad is those triglycerides. We really want to keep those triglycerides dialed in. The reason why is because our brain is made up of fat, okay? The substance of our brain, okay, the actual matter of our brain is primarily made up of fat and cholesterol. It needs essential fatty acids. It needs cholesterol to function. So when we go too low, which oftentimes statins do, we often then we get depression and those types of symptoms, suicidal ideation, etc. And then besides that, statins also have a lot of other issues. You're mentioning how it makes your irritable bowel syndrome worse. It can cause muscle dystrophy, atrophy, and problems with, different aspects of inflammation and a driver of such. So statins, and I don't like when patients are on statins. If it's working well for you, for some patients, if, I don't want you to now stop your statin. You don't want to just stop it. You want to talk to your doctor. But there are other ways that we can reduce cholesterol besides using a medication like this that can have all of these damaging side effects, especially when it comes to mental health. Niacin, B3, very, very, very good for lowering cholesterol. Now, when we use niacin, it can have a flushing reaction, which people do not like. It can make you feel really hot, kind of, it does go away, but it can be uncomfortable for some people. So you can use a flush-free niacin, which this still has research and efficacy, though a lot of the research is on the flush niacin. Your niacin, not niacinamide. Niacinamide is the flush free. Now the dosages for this are high, so we're looking at anywhere from 1,500, 3,000 milligrams of niacinamide. May need higher. So talk to your doctor about that. Using niacinamide to help with lowering cholesterol, you would gradually get yourself up to those higher doses. So it's not something you would do right off the bat as high dosages. Um, Also increase fiber in diet, like I already mentioned about water, because your liver also has a factor here, your gallbladder does as well. So we want to support those organs as well. So the reason why your cholesterol stays high could be multifactorial. It could be from liver, because you just mentioned having the fatty liver. It could be from um, it could be from insulin resistance. It could be from um, the bile not secreting enough bile acids, to degrade down the fat that you're consuming. It could be from diet, so all of these factors. So definitely increase fiber, look at an anti-inflammatory diet, drink plenty of water, help your body flush. Stop drinking if you are sodas, all of those things that they are not good for many reasons, because they increase inflammation, but also they bind to they have phosphoric acid in it, and that binds to magnesium. So now you're depleting your magnesium. So stop with if you are drinking those things. It'll also help your irritable bowel. Um, I would also be looking at leaky gut markers, seeing if you have LPS antibodies, like IgG for LPS. Um, that would be something that you could potentially, could be a factor here, because leaky gut permeability, caused by the endotoxin lipopolysaccharide, or LPS, can also drive insulin resistance in a picture like this, where you have um, elevated blood glucose, you have elevated triglycerides, and weight gain. So those things can also be problematic. Now, these medications themselves, olanzapine and mirtazapine, like I mentioned in the very beginning, that was the first question we had, um, can cause weight gain and even metabolic syndrome by the way it manipulates hormones, histamine, leptin, ghrelin, and even has factors on the your lipid particles, and how we can break them down. So those medications in themselves, hopefully you change from those medications and you're not affected in this way, but they can also contribute to this picture of metabolic syndrome, this high cholesterol, and make it difficult for you to manage for it to come down. So talk to your doctor about these natural ways. Talk to him about niacinamide. See if that's an approach you can use, to help lower your cholesterol. Of course, omega-3s can also be helpful, because they help with lowering inflammation, and can help with that HDL-LDL ratio, as well. So that could also be utilized, but definitely best research for niacinamide. Very good question. Thank you much for your answer. Would you mind if I email you? You can certainly email me. I believe you've emailed me before. It might not get to you right away, though. My emails are backed up, but I could certainly help answer. Emmanuel Aguilar, hello. I have been taking clonazepam daily since August of 2005 under the guidance of a psychiatrist. I am obedient to my psychiatrist. That's great. If you're doing fine with clonazepam, so you've been taking this for almost 20 years now, and some people are fine with the medication that works for them, like if it's a benzodiazepine. So I don't want to make you feel like you have to come off of your benzodiazepine. When we were talking about benzos earlier, um, it's just something that if you are having trouble, if you're having rebound anxiety, if you've noticed a pattern where you had to go up and up and up, and now you're on the max dose and you're not getting better, you're getting worse, that's when you want to start thinking about, whoa, maybe it's the clonazepam that's causing my problems. If you're taking it as prescribed, you're doing well, there's no problem, then that's great. Not everyone is going to have these issues with benzodiazepines or these other issues, even with the GABAergic drugs. But there is a large handful that do, unfortunately. And those are the patients that I tend to see because I work on helping them to come off of these medications, which is very, very difficult. It's a difficult road to take, and a road that you probably will only want to take after being on for so long, if it's absolutely necessary, because coming off of these medications can actually be more detrimental when we're looking at risk versus benefit for some people, versus staying on the medication if it's helping you. But if you're at that max dose, if you're taking 3 milligrams a day, 1 milligram 3 times a day, and you're not getting benefit, you kind of hit the wall, it's now kind of reared its ugly head on you, then yeah, you want to consider coming off of it at that point. But I'm glad to hear that you are abiding by your psychiatrist, and it sounds like perhaps doing well. So that's good. Delilah Jane, hello. How long does it take for our body to wash out antipsychotic injections? I took paliperidone 1 month injection 6 months ago, and from recent blood work, my prolactin levels are super high. What should I do? 6 months ago. Okay. And then you just had recent blood work after 6 months. So that should have washed out by 6 months. Sometimes, are you having, so the thing is with prolactin, I'm not really sure how long the effects of paliperidone. I know it's one of the ones that's that's in Vega, that does increase prolactin quite a bit. That one, and risperidone as well. So it depends on, if, like, as far as what should you do if the prolactin levels are causing a problem with your overall health. So are you having expiration of breast milk? Are you having, breast tenderness and these types of things because of increasing your prolactin? That's what I would be thinking and asking. If you still need antipsychotics, one that could actually help to block this effect is Abilify or aripiprazole. So talking to your doctor about that instead, if that's something you want. If nothing is really a factor with the prolactin, I mean, obviously, high levels of prolactin long term could also lead to other problems, inflammation, and other hormone dysregulations over time. But because you're not taking it anymore, should start to decrease over time on its own. If you are taking another antipsychotic, though, if you say switch from paliperidone to something else, maybe you're now on an oral, you're still gonna have this prolactin increase that could occur. So then that's when I would start talking about using something different. Like I said, like Abilify can be used here to help lower the prolactin and mitigate that response. So just something to discuss with your psychiatrist at this point. I would say by 6 months we should start seeing. So I'm not sure if you've had labs before and then labs now. We should certainly see a decrease if you're not taking any antipsychotic. Either orally or injection. But if you are still taking an antipsychotic, either orally or injection, then I wouldn't be surprised that your levels are still high, because that's a side effect of those. So something to just talk about with your provider then. Skelly MC, hello. My doctor has put me on tianeptine, 12.5 milligrams 3 times a day with Trintellix. Do you have any experience around it? You have talked a bunch already of Trintellix. Tianeptine is kind of a weird one. Yeah. One of my channel members brought this up to me, and I just touched the surface on it when I was looking into it to prepare for the last live that I did with them, and said I was going to look more into it, which I have. I do not have, right, it's not USA based, so I do not have experience with this one. It is being abused, though, as something termed gas station heroin. and so when I started digging into it and finding all of this out, um, what I have seen is that it binds to the opioid receptor, several different ones. Um, the mu one and then the delta opioid receptors as well. So that's why people are getting like this high from it. But it can also cause problems with decreasing, respirations, like what happens with opioids, right? So people can actually overdose, unfortunately. I'm not sure the dosages of it. It sounds like that's probably a lower dose. From what I recall, I believe the dosages that were causing these reactions were in the hundreds, like 200 milligrams, I want to say. Um, but it is something I'm just still working on researching at this point to come up with the video. That's going to be one of my next videos that I come out with, because one of our members brought that up. So I'm still in that research phase, but finding out a lot about tianeptine. Um, I don't know combining it with Trintellix. Um, I don't have any experience with it. But this tianeptine, I really don't understand why it is still approved in other countries based off of what I've been seeing. The safety data of it is scary, when you look at it, and the side effects that people are getting with it. So, I just, like I said, I just don't know because I don't have experience using it in this type of way. And from what I've been seeing in the research, yes, it has some efficacy for depression, um, but it's not working in the same way as we thought. It was termed as a tricyclic antidepressant. Newer studies have, when they've really dialed in and started looking at tianeptine, have showed that it has no action on the monoamine neurotransmitter. So no action on serotonin, dopamine, norepinephrine, none. So it's misnomered. It's named as a tricyclic. It's an opioid agonist, is what it is. And so they're trying to figure out that mechanism of action in depression. So they're kind of using as a model, but trying to find something that's a little safer as well. So it has kind of opened up avenues for research for other medications that could potentially help. Um, and maybe this is why, things like ketamine, can be helpful, and maybe even mushrooms and things like that. Maybe they're working in some of these pathways. So they're trying to figure that all of this out. But right now, it is illegal in the United States. Now, it's not used for medical use. What I should say is that um, because it is gas station heroin, so they're using it as like a nootropic and labeling it as that. So that's not illegal in all of the states, but it's illegal for like me to prescribe it. So for prescription use, it's not FDA approved. It's not something that I could prescribe to anyone. And then you have to be careful with these nootropic formulations of tianeptine that are being used as gas station heroin. I think some of the terms are like Zaza or Red Tiana, or something like that, or I can't remember exactly off the top here. Something like that, something like Tiana, Red Tiana, or something that it's nicknamed as. So that's having some components of this tianeptine in it, but there could be mixed in other things. So people are unfortunately, having some fatal overdoses, but also um, if it's not fatal, very critical emergency room visits because of these types of um, over the counter gas station heroin formulations. So it is being slowly eliminated. Like I know the state of Florida just eliminated it here. So it is illegal now in Florida. And other states have also banned it, but not all of the states. So I think they're working on trying to get it banned nationally here in the United States as even a nootropic, but it's not a medication. And unfortunately, because of that, I don't have any experience around using it or even combining it with medications or antidepressants. But I would definitely talk to your provider about these concerns, about it. Maybe they can help you. Grant Rennie, hello. Can I ask about Selank or CMAX? CMAX. Yeah, I'm not sure that medication. Is there another name for it? Sometimes other medications have other names that I may be more familiar with. Um, but you can ask about it, but I don't know them off the top of my mind. These two drug names do not ring a bell. Sorry about that. Emmanuel, hello. Why is it I have been taking 1.5 milligrams clonazepam for 19 years, but tolerance did not develop? That's always why my psychiatrist prescribes. Please explain. Well, we with the issue of tolerance and why some people develop tolerance and others don't is something that is not completely understood. So, 1.5 milligrams of clonazepam for 19 years, no tolerance. I think that's great. You should count yourself as lucky with that. And that is something that you do want to, because you'll max out about 3 milligrams. Um, unless there's some providers who will try to go above that recommended max dose on clonazepam, but typically maxing out would be 3. If you go above that, you're really risking a lot of issues with um, liver and other side effects. But anyhow, like I said, we just don't know why some people develop tolerance and others don't. I would count yourself as lucky that you haven't developed tolerance, because when you do, it's very troubling. But I'm glad to hear that you're not, and that your psychiatrist prescribes it for you and it's working. I think that's great. Corey McDonald, hello. I have been trying all the SSRIs, SNRIs, and they don't work. I get either feel too weird or too wired or very sleepy. What is a good option to try? Corey, how about you step out of the psychotropic world, meaning the psychotropic medication world, and maybe look into more of there's something else going on. Um, Unfortunately, in our society here, we want the quick fix. We want the pill. When oftentimes the pill is not the answer. Not saying that it doesn't help people. Um, Antidepressants can be very helpful. Long-term use, however, unfortunately tends to have more downsides than good, because of treatment resistance, inflammation, all these other issues that occur with long-term use. So we can use them short term to help maybe blunt emotions, to help work with building skills, to help you, to eventually come off of them. That would be the preferred thing to do. But the reason why they may not be working may be because really they aren't the answer. You don't have a serotonin deficiency or a norepinephrine deficiency. You don't have a Paxil or a Prozac or an Effexor deficiency. Okay. The chemical imbalance theory, by and large, has been debunked in the fact that the majority of people who are depressed do not have low serotonin. Not to say that serotonin doesn't play a factor, because it can, like I said, with your nutrients and things like that. When you try to manipulate that as just a singular thing, and that's not really what's going on, and there's something else going on, it's not going to work. And there are some people, genetically speaking, who just have more predisposition to effects on serotonin because the way that their serotonin receptor gene acts, or maybe doesn't act. Okay. So there's a genetic component perhaps there with the medications and why you're having reactions to them. But it could also be that it's not your thing. You don't need medications. Oftentimes that is the case. So I would look at mental health labs. I would look at what else is going on, thorough labs. I would look at optimization. Usually when you do a lab in your doctor and someone comes to me and says, "Oh, but my doctor did my labs," and I'll say, "Can I see them?" and it's a CBC, a CMP, and maybe a TSH. That is not enough. We can look at that and say, even if it's normal, kind of see trends of where you're going into out of optimal, because that's what I prefer to look at, is the optimal ranges of labs. Because when you're looking at labs and you're normal, abnormal, when you're abnormal, you're already in a disease state. You're already like way off the rails. We want to get you before you jump off the rails into abnormal, right? We want to dial things in. And before you get off the rails and abnormal, you have your brain is the organ that is most affected. Meaning, for instance, a good example is vitamin D. So you'll have someone with a vitamin D of 33 and it's normal. So their labs come back, everything's normal, but they have a vitamin D of 33. And I look at that as, oh no wonder you're depressed. No wonder you're having problems with mood, because vitamin D is a prohormone and it has many functions all over the body, including the brain, and is very neuroprotective. To dial in on vitamin D, we want 50 to 100. So if you're 33 and what the labs will say is anywhere from like 30 to 100, so you're normal at 33, no wonder you're having problems. Your brain, being one of, a very small organ, maybe the size of your fist, requires a lot of nutrients, okay? Probably one of the hungriest, you could say, organs in our body that needs, because it has so many metabolic reactions happening and neurotransmitters. Everything is happening from our brain, everything that we do, right? So when you have a subclinical deficiency, guess which organ system gets affected the most? It's your brain. So subclinical deficiencies, yes, cause or lead to mental health symptoms. Okay. When you have vitamin D's in the 20s and teens, now we're looking at psychosis. Now we're already off the rails. We're not only like treatment resistant depression, we may have depression with psychotic features, we may have schizophrenia. That's when you're going off the rails. So do we want to be off the rails before we catch something, or do we want to be maybe suboptimal, catch it and get back on track, right? And stay in line, stay in those optimal ranges. So that is what I think about when I have someone who says these medications don't work. I think, well, why are you looking at medications? Why not look at other factors? Because most likely it's not that. It might be nutrients. It might be anemias, which goes back to nutrients, iron deficiency, B vitamin deficiencies, magnesium, vitamin D. It could be hypothyroidism. It could be Hashimoto's. It could be inflammation. Inflammation is a huge driver. Again, that's one of the videos on my list to do is one on inflammation and depression. Inflammation is a huge driver of depression. And so autoimmune conditions, if you have overactive autoimmunity, if you have gastric permeability, all of these things could lead to these symptoms, and antidepressants, they're going to make it worse. I just told you how serotonin and too much serotonin in the gut creates inflammation, which can make things worse. So that could be why you're not responding. So I would look at labs, mental health labs, basic labs that I talk about in the video, optimizing those. Also look at genetics and see genetically. So like a Genomind test, a gene site test. I prefer Genomind because you get way more genetic SNPs, single polymorphisms tested than you do with GeneSight. And I just love their report more. Maybe I'll even do a comparison video of those two for you guys to see that. But and I'm not sponsored by them. I just like them, okay? And so you can see that. But first I would start with the labs, then look at maybe genetic factors with medications. Maybe you're not metabolizing things properly. Maybe you're over responsive to serotonin modulation before considering what else you should try as far as medication. Okay. Sorry, long answer, but I do get on these soapboxes for a reason, because I want you guys to know that medication is oftentimes not the answer. Okay. And we got to look and dig deeper. So that's why I go down these rabbit holes, because it's important to me that you guys understand this. All right, next question. Senthil Nathan, hello. I am on diazepam 4 milligrams and also on SSRI fluvoxamine 125 milligrams and mesulpiride 25, pregabalin 50, melatonin 3. Is it fine to taper benzo first and then anticonvulsant and then antipsychotic and then SSRI? Yeah. Or maybe save the antipsychotic for last. It's up to you. Um, Benzo first, good for in my opinion, okay? Um, could be good here because so there's a couple rules of thought of when you're on multiple medications on which to taper first. So when you're going to embark on this journey, some providers will do, let's do the get the benzo out of the way. It's the hardest to come off of, and we don't want you to have already been, maybe, your brain having withdrawal symptoms in a state when you're coming off of these other ones, right? So we want maybe these other medications on board while you're coming off of the benzodiazepine. In your case, because you're also on pregabalin, it may be easier for you to come off of diazepam. Still have to do it very slowly, right? Then the anticonvulsant, which is pregabalin, you could do that second to see, how that's going. That would be like the second. When you're looking at worst to least, I would say it would be the benzo, the pregabalin. I would say it would be the SSRI before the amisulpride. Okay, so it would be the fluvoxamine before, if we're going to do worst to least. Okay, um, then we have the other side of things. So the other way would be to go the opposite. So why would you want to do that? To build confidence, to help you to see how the process works, because going with the benzo first can have its challenges. Okay, and you would have all these medications on board to kind of help be there as an anchor, but it could turn someone off from deprescribing because of the uncomfortable. Even if you go slow, most likely you're gonna have some kind of withdrawal symptoms from it, and that can turn people off, and then you kind of get frustrated, you get upset, and so a lot of things can go sideways fairly, very easily when it comes to tapering off benzos. So some providers or patients will prefer to wait to use for that, for last, just because of that, where others will say, hey, it's the hardest to come off of. Let's get off of it while we have these other medications on board, right? Just so you understand, doesn't mean it's going to be easy breezy. Coming off of medications, by and large, especially when you're on multiple medications, is never an easy road. So hopefully, Senthil, you've spoken to this with your provider. You're making this decision based off weighing your risk versus your benefit. If these medications are causing you more harm than good, and you're ready to come off, or you feel like your mental health is at a place where it's stable and you want to see how you are without medication, those are all reasons to want to taper. If your health is a factor, maybe your liver, with all of these medications, I wouldn't be surprised your liver enzymes are elevated. Maybe that's a factor. Um, so all of these things you want to consider and weigh out risk versus benefit when you're talking about deprescribing. Okay, your age is also a factor. The older you are, the harder it's going to be, unfortunately. Okay, so keeping that in mind, talking with your provider about it, working this out, deciding for yourself which way you want to go. Do you want to go hardest, down to the least, or do you want to go least, save the hardest for last? It's really a decision for you and your provider to talk about and to make. I've seen it done both ways. Okay. And I would say, just because you have both the pregabalin and the diazepam on board, um, that it would be a wise choice to do the diazepam first, because you have that pregabalin that'll help anchor the withdrawal, in my opinion. Okay. just by looking at all of those. But by and large, it doesn't mean that it's going to be easy. You still have to go very slow, even though diazepam has a long half-life. And make sure that you're not on these medications for preventing seizures and you don't end up having, status epilepticus or some kind of, seizure disorder come back. That could be life-threatening. So again, all reasons to talk this over with your provider, and you're working with someone who knows how to really taper these down, and dial in on tapering these down safely for you, and helping you to monitor your symptoms and know when to slow it down, know when it's okay to maybe speed it up a little bit if you're doing well. So that's all very, very important. One channel that's really dedicated to tapering is the Taper Clinic with Dr. Joseph with During. I did an interview with him, and his channel is completely dedicated to tapering medications. So he may have more specifics on this topic. I'm not sure. But he also, that's all he does is taper patients off of medication. So he's an expert in this field more so than I am, though I do help patients with tapering off medications. It's not the only thing I do. I focus more on a holistic approach to finding root causes to mental health symptoms and helping to mitigate them using, more natural diet, lifestyle, those types of changes, where he is more, that's all he does is deprescribe, and that's all his focus is. So, I would say that would be the expert resource in this topic that you could look into and see, and see if perhaps you can get any information from his channel as well. But very, very good question. Ganesh T, hello. Ma'am, I remember you said your husband has ADHD. Oh, yeah. Can you share how your husband handles ADHD with technology like app to-do list and anything else? Yeah. I have many milestones and daily tasks, but I get confused how to start and from where to start. And sometimes I even forget I need to do many things, how technology can help and which your husband's use. So, several things. One of them is he was using something like Todoist. That's actually one that I use. Though I don't have ADHD, I just use it just to be on task. um, and I believe he's now just using his calendar. So using like Google Calendar blocking with reminders, and then quiets all of the noise. So only focusing on the one thing in front of him, and then he puts all his other tabs. He's got multiple screens because of the type of work that he does, but he'll put all of the tabs like he's looking at in one screen, and then the one thing he's focusing on is the only thing that's open on the screen right in front of him. So he does use he has got 3 screens that he works with, and he separates them out into priorities, the thing in front of him, and then the things that he further goes into with his research and all that are on other screens, and then he brings them in one at a time to help organize his workflow, okay, by what he needs to have in front of him as priority is just the one thing in front of him. Turns off all notifications. The other thing that he does is, so his phone is on silent, no notifications dinging while he's working. So anything on the computer that is popping up for you, you can silence all of that. Silence your phone, okay? And then the other thing is a timer. So he does blocks of time. So usually first thing in the morning, he's doing blocks of time by an hour or 2, depending on how he feels, and utilizing a timer that's up in the corner of the one screen that he has on the right. It's kind of there, and then it goes off. And guess what he does? He steps out of the room. He'll do some stretching. He'll get outside. He'll get some light, some vitamin D. He listens to the things that I say about mental health, takes a, quick 10-minute break, and then boom, the timer starts again. 2 hours, 1 hour. As the day goes by, he lowers that timer a little bit because his mental capacity isn't as great as the day goes on. He also uses some adaptogens, Amare, the Happy Juice. So that's like Amare Edge blend, and the Mentobiotics and the Energy Plus, okay, the Happy Juice. Usually he's more doing the Edge and the Energy Plus ones as the help for that's like the Happy Mind mix, I believe, in their line to help him, like especially during that slump that he starts to get in the mid afternoon. So he'll use that as adaptogen, and then boom, he's like back on it. He starts doing those 2-hour blocks again. If he notices he's winding down and he needs to keep going because he has long hours. He starts his day off usually around 5:36 in the morning, and he'll go on till 6, 7 p.m. in the evening. So that said, those are the things he uses. Time blocking. So his calendar, he's got that with what he needs to do. So he dedicates certain blocks of time for certain things. He has the timer, so that keeps him on task. He keeps one thing in front of him on screens. He separates the other things on two different screens and only focuses on one thing at a time. And then turns off notifications. So those are the primary things. And then we'll use adaptogens if he notices his energy is getting low. Right around lunchtime is usually when he'll go to using adaptogens if needed. And green tea. That's what I always do too. Just for instance, before coming here, I did the green tea, and I did actually do the Energy Plus today with my Mega IgG because I've been having some reactions. So that helps lower my reactions. But anyway, to help keep my mind, not that I have ADHD, but just to keep me focused, to keep me dialed in. The not only the caffeine from the green tea, but it's that EGCG, very, very helpful, and L-theanine, very helpful for focus. So all of those things. But when it comes to technology, at this point, he's just using his Google Calendar and then silencing notifications and then separating his work. He uses 3 screens in his office, and that's how he works. So, another thing I forgot to mention is he always has something playing, a focus, like lo-fi focus beats. I forget the channel it is that he likes to have on, but he always has like a lo-fi. It's a focus channel with just ongoing music that's playing. It's on YouTube, so he has that playing in the background as well to kind of help keep the focus. So those are either the lo-fi or the binaural beats for focus. Either one of those is what will be playing in the background when he's dialed in and doing all of his work. It helps also to keep him focused. So that was the other thing I forgot to mention. But yeah, so he does a lot. Senthil, yes. Hello, Nathan. Diet to follow. As in India, it's heavily loaded with carbs. Oh, yeah. And less protein. All of these medicines I took due to severe withdrawal effects faced due to a doctor who prescribed Xanax for palpitation. ISS. I'm not sure the ISS part, but for palpitations that you were having. Okay. So diet to follow, like I mentioned before, anti-inflammatory diet, very, very good. Now in India, you could probably leverage a lot of the herbs and spices you use, curry, turmeric, those types of things. They're anti-inflammatory. And maybe going to Mediterranean style diet wouldn't be a big stretch for you. So maybe start there before jumping into anti-inflammatory, because Mediterranean diet also has some literature where it can reduce inflammation. Now, when you're doing a Mediterranean diet, does have carbs, but it's using more whole grains as the carb source. So you're eliminating simple carbs. What I mean by that is like white pasta, white potatoes, white rice. You're using more of the grains, quinoa. You're using more protein-based carbs. Um, Sweet potatoes, for instance, instead of regular white potatoes, keeping those skins on for fiber, because the more fiber you have, like, and that's why these grains are very helpful, because they contain prebiotic fibers that feed the gut, that help with digesting things, but also help with your glycemic index. So what that means is, so your sugars, when you eat simple carbs, white bread, for instance, your sugar spikes. It doesn't, when it's broken down, it doesn't recognize that from just simple plain cane sugar, right? It sees it as a sugar. Your sugar spikes high, then insulin comes into the rescue, boom, brings it down. So you get this roller coaster effect. When you are using more complex carbs, which are what are these carbohydrates that are using grains and whole wheat, okay, as long as you can tolerate that, a lot of people are gluten sensitive and don't know it. But if you can tolerate wheat and grains, then you're leveraging fiber as a way to break down that sugar instead of needing insulin to come into the rescue all of the time. And that helps to lower the glycemic load in the body and make it a bit more stable. So that's going to help prevent insulin resistance, prevent inflammation as a driver. So perhaps just switching right now to more of a Mediterranean style would probably be an easier transition for you. So that, and then with your carbs, looking at more complex carbs, using more grains, looking for pastas and rice that are made with like brown rice, wild rice, looking at quinoa instead of rice, as a grain, and using those things for pasta, using like vegetable noodles like zucchini. They're called zoodles here in the US, where you take zucchini and you can actually make noodles from zucchini. Very, very tasty, instead of the pasta. All right, so now you're using a vegetable instead, which is really, really great for feeding your good bacteria as well in the gut, and with giving you nutrients for mental health. So all of those things can be very, very helpful. And when it comes to detoxing or deprescribing, um, and dealing with withdrawal symptoms, oftentimes you are inflamed. Oftentimes you do have a lot of inflammation in the nervous system. So after you switch to more Mediterranean, like get comfortable with that, then I would really look into dialing it in a little bit more into more of an anti-inflammatory diet, and really look at leveraging increasing omega 3s in your diet and really lowering the inflammatory burden um, as well. But I would first transition to Mediterranean, then make the transition to anti-inflammatory. Next step would be like keto or carnivore, which would be very, very, very strict, but huge, huge, huge studies with how that helps with mental health and inflammation and all of these issues that could be drivers of mental health symptoms and even drivers of withdrawal. Now, I don't know of any connections with ketogenic diet and withdrawal symptoms, but just kind of deducing the fact that the ketogenic diet reduces inflammation significantly, as well as really helps our brain function better. We're more alert on a ketogenic diet. We make better neural connections on a ketogenic diet. BDNF increases, all of those things, which are very healing for the brain. Um, Stepping to that kind of diet can actually be very, very helpful too, and has been helpful. One of the diets that starts off very strict and I think it's called the GAPS diet. And I forget that acronym, GAPS diet, something like gastro, something psychiatric symptoms. I can't remember. But the GAPS diet is one of those diets that is specific for mental health symptoms, and is very, very strict. Doesn't start out strict, I believe, like it kind of ends up being strict. But I do know, I want to say Angie Peacock had Adele Framer on talking about this GAPS diet and talking about how she tried it and just like kind of some of the research behind it and talking about it. And that's Angie Peacock. She's got a YouTube channel, and she's also a consultant for helping patients with deprescribing. Now, she's not a doctor where she can prescribe, but she does a lot of coaching and group coaching in particular so that you don't, you're not alone. So you'll get a really good place to find hope in coming off of these medications, because it gets really muddy when you go into those forums and you start getting a lot of negativity in a lot of those forums when you're talking about coming off medication. So you could look there if you're interested in that kind of diet. I know that's even more strict than keto, but you may find some benefit with that too. Um, and then another coach I did an interview with, Coach Powers, Dr. David Powers, he focuses on the limbic system and working on dealing with the inflammation in the brain from that angle and really helping develop skills. He's got a course that you could sign up for, or you could do one-on-one coaching with him as well as with the course. But his prices are very reasonable, and that course that he has is very reasonably priced as well. I believe it's like a membership. I want to say $30 a month or something like that, where you can learn about how to use your limbic system and leverage skills, which is what I talk about a lot, to help lower your inflammation and lower your anxiety. So using those kind of things together can be very, very helpful as adjuncts to your tapering, and again, getting guidance, from experts like, Coach Powers and Angie and uh, Dr. Whit During, Yosef. So those, things are good to look into. Stay away from just basic forums and all of these negative stories, because that creates negativity around it. But yeah, I would definitely start leaning, in your case, more towards Mediterranean, anti-inflammatory, and then look into maybe some of these other diets to really leverage the power of nutrition to help you in withdrawal. Viral Shorts 05, hello. Why psychiatrists say that stomach issues is because of mental health. Even antidepressants cause my stomach issues itself. Good point. So the reason why we say that stomach issues can be a mental health problem or vice versa is the gut-brain connection. So I made a video about this a while back. Maybe, Raul, if you can find it, you can put it in here, because we've had several questions about this. And I've been talking about this gut-brain connection. I think it's important for people to understand what I'm talking about. So the enteric nervous system is the nervous system that's in your gut. So there are many ways that our gut connects and communicates with our brain. Enteric nervous system is one of the main ones. It's directly through the nervous system, vagus nerve, highway, boom, they're dialed in. So when you hear people say, I feel nervous or I'm anxious, and then they get butterflies in their stomach or they start to get nauseous, that is that boom, that connection, hypothalamic pituitary adrenal axis kicking in, letting through the vagus nerve, saying, hey, things are going off. We're getting a little nervous, and things in the enteric nervous system start signaling to the gut. Now, initially, it's like, quick, we got to get rid of anything that's in there. So that's maybe where you'll have diarrhea or some nausea, or feel like you're cramping. Maybe vomiting can occur with really acute nervousness. Prolonged, it can actually lead to constipation, because it's saying we don't want to focus on digestion per se. We want to slow things down because our body is in this chronic stress. It's chronically producing this cortisol, and so the vagus nerve and everything kind of shuts down and doesn't really work like it should. You're not in rest and digest state. So the other way is also through the enteric nervous system, but via the microbiome, the gut microbiome. So the gut microbiome, our communicates, through many ways by how it breaks down our nutrients and supports our digestion, but based off of what we're eating, can send signals through the nervous system of, things are good or things are bad. Okay. And are also helpers, at least the good ones. The beneficial bacteria are helpers in the digestion process and even producing these nutrients that we need, like vitamin B, B12, etc., for mental health. Okay. We also make, like I said, most of our serotonin in our gut. However, it's not doesn't cross the blood-brain barrier. Serotonin in the gut has a different function than serotonin in the brain. So just to make that clear, because a lot of people think serotonin is going up to the brain from the gut. That's not the case. However, based off the serotonin in the gut, the brain responds to things. So signals to maybe the vagus nerve to kick in or kick off, or for you to be more focused or not. Okay. When you have too much serotonin, so why antidepressants are causing this stomach issues itself, because of that serotonin in the gut. When you make too much serotonin in the gut, it's inflammatory. Like I mentioned in the beginning of how the question was about olanzapine causing weight gain, right? So you're causing now inflammation because of too much serotonin in the gut. That in and of itself can cause gut problems, okay? Chronic inflammation in the gut can lead to gut permeability, which is that leaky gut. That can then turn into greater mental health symptoms, because when you have dysbiosis, increased inflammation, unfortunately, that is the environment that the non-beneficial bacteria strive in. And a lot of them are gram negative and are lysing something called lipopolysaccharide. Their membrane, their membrane, endomembrane, I think it's called. And that LPS, lipopolysaccharide, is neurotoxic. In a healthy gut, the beneficial bacteria keep that production down. It's still happening because we do have some gram negative bacteria that are actually good for us. But because the membranes and the mucous membranes everything's intact, it's not leaking through into our immune system, okay, and being shown to our antibodies. That's why I said for that one person to check their LPS, their IgG, but that's an antibody to LPS. You shouldn't have that. LPS should not be circulating in your system at all. It should be produced within the gastrointestinal system and excreted out into the stool. Okay. So we'll see LPS in stool, but we also don't want to see too much of it either. There's got to be a balance of it. Okay. So high LPS signals neuroinflammation, neurotoxicity. That's directly coming in from the gut. Okay. That unfortunately can cross the blood-brain barrier, can lead to brain inflammation, can lead to So this is how this connection, it goes deep. So when we're looking at the gut, we're looking at the nervous system, the immune system, and the actual digestive system itself, and the microbiome. Okay. And remember, if you watch the video, the playback live that I did with Quran, he talks about that, which is so true. Our DNA, when is actually not that sophisticated. What makes us sophisticated is actually the DNA of the microbiome on our skin, in our gut, all over. We have more microbial genes than human genes, which is mind-blowing to me when I try to wrap my head around all of this. But he explains that when he talks about the connection with the skin, the gut, the brain, etc., because he's a microbiologist and can explain it in that way. But really, the bottom line here is that there is a connection, which is why the approach I take is the approach that I take. We can't just look at the brain and say, here we go, let's just give this medication. Let's just give this brain SSRIs, SNRIs, and forget about what's going on in the rest of the body. We are connected. We have a neck. We are connected with our gut, our nervous system, our immune system. Everything is connected, and we have to take a step back and look at this as a whole. And as Karan mentioned in that interview, is that unfortunately medicine has compartmentalized everything into, you just focus on this, you just focus on that, and you just focus on this, right? So for psychiatry, I just learned Let's focus on the brain. Let's focus on what medications can help target the brain. However, I had to take a step back myself, right? When I was going through my own issues and realize, oh, medication, maybe not the answer, and educate myself on these other things so I can help my patients in that way and guide them in the right direction for treatment for mental health symptoms, because we're taking a holistic approach. That's what a holistic approach means. It's looking at mind, body, spirit, all of it together, not just singularly as one. And that's what we're talking about with this connection with stomach issues and mental health and the gut brain connection. So if you want to look more into it, I advise that you look at the live with Quran. That's very good. If you look at the gut brain connection video that I did, that helps simplify this a little more. And look also for the labs for mental health. That'll help give you a picture of what I'm talking about with whole health and all the markers that I'm looking at to help decide on what would be a good treatment for someone with mental health issues. Because you're right, it could be stomach issues. It may not just be, it's not just all in your head. Could actually be a lot of other things going on in your body that we need to address. And oftentimes the gut is actually a leading factor of problems. It's oftentimes a root cause. Okay. All right. All right. I'm taking escitalopram 10 milligrams and want to take the ADHD medication after I get an ADD test. Is there an interaction between escitalopram and ADHD medication? Yeah. So with SSRIs and stimulants, you can actually increase your risk for serotonin syndrome. So stimulates can actually cause some overactivation of that serotonin release. So that is something you want to be careful with and discuss with your provider. It can be done. There are patients who are on Lexapro and say Adderall, but you just have to be aware of what those risks are. Maybe reduce the dose of Lexapro if you're already on a max dose. Just talk to your psychiatrist about it, your provider about it, about things to monitor, know what serotonin syndrome is, and monitor for that. That would be the number one thing that I would be discussing with my patient if they wanted to add a stimulant in their treatment plan and they were already on an SSRI. Be on the lookout for serotonin syndrome. I have a video on that, by the way, if you want to learn more about it. Okay, next question. Daniel Duran, what's a good replacement for Abilify and olanzapine in adjunction? It says ability, but I'm pretty sure you mean Abilify. I'm not sure what you mean for like treatment resistant depression when you're saying adjunct, because there are a lot of others that could be good replacements. For example, if you're not doing well with either of these antipsychotics, especially Abilify, say Abilify was working well for you, maybe you were just having a couple, some of the side effects became intolerable, you could switch to Rexulti, which is brexpiprazole. And oftentimes patients, when they switch, they'll have a lower incidence of side effects, and that is for treatment-resistant depression. Others are, Vraylar, lorazepam. It depends on what you're trying to achieve. When you're talking about in combination, though, so I just want to make sure I'm understanding the question, because I'm taking that, I might be taking this question wrong, the way that I'm reading it. I don't want you to be combining antipsychotics. Okay, so I don't agree with that approach. So I don't agree with using two antipsychotics. Sometimes Abilify, though, is used in low dosages with another antipsychotic, like maybe Risperdal or Invega paliperidone, because they want to block the prolactin. Okay. So I could see that. All right. Aside from that, and that's, patients who are high dosing these drugs. So we're talking about schizophrenia patients for the most part. Typically, you're not going to see those high dosages in someone treatment resistant, and so I wouldn't be using two antipsychotics for that case. Um, I'm no longer in a community mental health setting, so I don't treat schizophrenia. So I'm not really in that world anymore with all of the antipsychotics and what to use. So if that's what we're talking about, I'm sorry, my advice may not be as, up to date with schizophrenia, but I do know that when you are using multiple antipsychotics, you increase your side effect burden tremendously. So that needs to be weighed out. If we're talking about just replacing these with something different, like if you want to replace Abilify with something maybe that'll be more tolerable for you, Rexulti. If you want to replace olanzapine for something that maybe isn't going to cause as much weight gain, maybe Latuda, okay, Vraylar, so that's what Caplyta, so these are the things that we're thinking of it, and it just depends on why you're trying to change and what you're trying to treat when we're talking about alternative medications and looking at them. And of course, if you were just here for the past 15 minutes, you just heard me talk about all this other stuff, the gut brain connection, everything else. So, you know, making sure that that's all being looked at as well. And we're not just looking at this in a box, that we're looking at the whole picture. That's very important too. So all of those things before looking at replacements, etc. But good question. All right. Drops of Jupiter. Hello. Went off fast Lexapro. Oh, didn't know I was in benzo tolerance. I'm 69, having a hard time tapering benzo. Can I go back on an antidepressant? Does anyone reinstate? Yes, yes, yes. So many patients will reinstate their medications, especially if they're having a hard time. You got to go back, slowly. So go back to, the last dose you were on. If we're talking about reinstating the benzo, if you want to go back on the antidepressant, that's an option too. But I caution you, because if you're already in a benzo, like a bind situation, the benzo-induced neurological dysfunction, so there's already that going on. Unfortunately, you may be more susceptible to, if you start another psychotropic medication, whether it be going back to Lexapro that you were on before or something else, you may actually be more susceptible to side effects or adverse effects of that medication. So do so with caution. If you're thinking about going back on the Lexapro, just bring it in real slow. Like just bring it in at 2.5. Let's see how you do. Like that's what I would be thinking. And see if you could even tolerate it. It's like dipping your toe in the water, seeing if it's too hot or too cold, right? And so that's how I would approach this, very, very slowly, very cautiously, because we don't want to get your nervous system, especially if you're already in that state. It's very difficult, unfortunately, when you get to this point. And this is the warning that I talk about with benzos and when patients are at this stage. So if you were already reducing your dose of the benzo and having a hard time tapering, you could always consider going back, to, your last dose, and kind of slowly go back until you get back to stable, and then hold there for a while, reevaluate your taper schedule, and perhaps go slower. I would look at doing that first before jumping to adding in a medication. And then, if you're still struggling at the last dose you were at to find, where you had stability, then I may consider, adding back like Lexapro, and thinking that may be a factor, but very, very, very cautiously. And again, like I said, the expert on the tapering is going to be Taper Clinic, Joseph Witt-Doering on this as well. Okay. Missy I, hello. I've been on paliperidone injections for over a year. Lately, my legs shake for about 30 minutes after I wake up. Ooh. My doctor checked with an EEG and it was normal. What should I do? Well, Well, that sounds like it could be an adverse effect. My legs shake for about 30 minutes after I wake up. There are a lot of these unusual movement disorders and things that happen with antipsychotics, especially long-term use. So if the EEG, so he's trying to rule out seizures. He's thinking, well, maybe this leg shaking thing for 30 minutes when you wake up is part of a seizure. So that's why your doctor checked the EEG. Um, and it was normal. So he's ruling out seizures. So the next step would be in the conversation. Okay, doc. So I don't have seizures. Um, can we? Maybe this is, an adverse effect to the medicine. Can we try to lower the dose, or can we think of other options? So that's what I would do. I would have the conversation with the doctor, like, now what? You ruled out seizures. Thank you for that. But now what? If that's the only medication you're on, then that's an easy like sell to the doctor, like, hey, this is what I've been taking. This is, or if that's what started it, like obviously it's coming from the medication as an adverse effect. Now, what he or she may say is like, well, it's not really TD because that's like those abnormal, tardive dyskinesias and things like that. And he'd be correct, or she would be correct in that. But there are these outlier kind of movement. It doesn't necessarily always have to be like the shoulder movement or the face movement. It could be something going on that's off, like the leg twitching. I would not say that that would not be an adverse effect of paliperidone. It could actually be an effect. It's just not something common. It's something that may be seen outside of the drug trials. So I would, be looking into that and seeing if either lowering the dose helps it or switching to something else helps. So that's the conversation I would have with my doctor if I were you, and had this situation happening. Okay, next, Daniel. Hello. Also, do brain stems help or worsen psychosis like ginkgo or bacopa? Yeah, bacopa monnieri, or ginkgo. Those are nootropics. So when you're saying brain stems, I guess nootropic medications that can help stimulate the brain, can be great for those with like ADHD or those needing some extra motivation and energy. However, you are right, Daniel, they can worsen psychosis because with psychosis, we're dealing with primarily, oftentimes, dysregulation in that limbic system, but a lot of dopamine activation. Okay. And so when you're increasing the um, dopamine, which ginkgo and bacopa monnieri can do. That's how they help with increasing that brain energy, and people with want alertness or want something natural for ADHD. These things can help. But because of that, yes, now you can eat. If you're on antipsychotics, you are now negating the effects of them. You're making it harder for them to work, and so that could actually be a factor, as far as worsening the psychosis. So definitely talk to your provider about that. And I would, if you are dealing with psychosis and you're taking an antipsychotic, I would not recommend nootropics like ginkgo or bacopa, or others like mucuna purines, and uh, there's several of them out there, more than several. There's tons of them out there. So I would not be doing that because you could actually, increase, psychosis. So, Raul is reminding me that we are at time, so we're past our 2 hours. We do have several questions, so let's answer these. We have 7 questions right now that have not been answered, so I'm going to answer these last 7 questions. If you have any more questions outside of that and want to put them in the chat, I will have my newsletter that comes out every month. I'll see what questions are left over, and we'll go ahead and I'll answer them. okay, in the newsletter. I answer about 3 or 4 in the newsletter. So make sure you're signed up for the newsletter. Go to levelheadedmind.com, scroll to the bottom and sign up for the newsletter, and you'll get answers to those questions that I don't get to answer. But he's telling me we have 7 questions. So let's see if we can let's go till 1:30 p.m. here and see if we can answer the rest of these questions. Okay, Eric, why don't keto diet fix my schizophrenia when other people say that keto diet has fixed theirs? There are many variable factors, and you're right. Keto diet has helped many with their schizophrenia. Dr. Chris Palmer has a lot of research on this. Georgia Eid as well. Metabolic Mind is a website you can look into this. There's a lot out there on this, but if it's not working for you, perhaps there are other things going on. Maybe there's some nutrient deficiencies. Maybe there's something else. Maybe the ketogenic diet can help lower your medication burden. So I know Dr. Georgia Eid, I've heard her talk about this before in some of her interviews where, you may not be able to eliminate your medication when you have schizophrenia, but you can eliminate the medication burden, maybe get down to just one medication, down to, lowest dose, for instance. So look at it as that way, as leveraging it as a tool. So may not completely cure your schizophrenia, but you could certainly still leverage it as a tool because you should be getting a lot of benefit on that keto diet for brain health, mental health, for lowering inflammation, for helping with psychosis, etc. And then also making sure that you're not ignoring other things that could be a factor, like vitamin D, for instance, deficiency. Significant vitamin D deficiency can lead to psychosis. And even if you're out getting sun, you may still have a vitamin D deficiency because your vitamin D receptor gene can't synthesize that vitamin D from the sun to usable source of vitamin D. Okay. So it's important. Some people need vitamin D, supplementation all their life because of that. It is important to check for that. It's important to check for other nutrients as well. B vitamin deficiencies, right? Check your vitamins, check your nutrients. Look at that mental health lab test video. Get some ideas to send to, give to your provider on lab testing. Make sure you're ruling those things out. And then your mindset, change your mindset. Maybe utilize the keto diet if you're on it, getting benefit to minimize your medication burden, okay? And not completely as a cure. But I would look at other factors as well on top of just the diet aspect of things for you. Okay. Daniel Duran, would psilocybin help or worsen psychosis knowing it may produce more neurons? So the thing with psilocybin is microdosing is key. This isn't an area where I have expertise in or a lot of information or even practice, because it's still kind of being developed in clinical research. And we do know like ketamine, working on the NMDA area section and improving depression via glutamate. So there's a lot of other pathways that are involved here when it comes to these psychedelics. Okay. Psilocybin is one of them. But I know that we're not trying to induce a complete psychosis state when we're using them. We're trying to microdose and just get below that threshold of that psychotic state, right? Not psychotic. I guess it's more of a transcendental state, like where you're kind of out of your body and you're having this crazy experience, right? Which could be considered psychosis because you're hallucinating, hearing things, maybe seeing things, etc. So we don't want that to occur when we're using psilocybin. And if you already have psychosis, I would say that would be a contraindication. So having psychosis and then trying to, even if you're going to microdose it, would probably still aggravate someone who is psychotic. At this point in time, to my knowledge, psilocybin and other psychedelics are being used for treatment-resistant depression, not for psychosis or for schizophrenia or those factors. So I would say that um, having psychosis would be a contraindication for using those, and yes, could potentially make psychosis worse. Mona Mac, hello. What is ODD? My cousin's diagnosed with it. Is there meds for it or therapy? So ODD is oppositional defiant disorder. Um, Therapy is first choice. There aren't medications specific for ODD. So therapy, behavioral, it's dealing with the behavioral issues of the child, um, and then trying to mitigate, any, because a lot of times when you have ODD, you are dealing with someone who's breaking rules, not submitting to authority, getting in trouble in school, those types of things. And this can lead to, conduct disorder. It could lead to sociopathic type tendencies and those types of things. So we want to nip it now, while they're young, and so therapy, behavioral interventions are number one. If they are having like anger issues, out of control behaviors on top of the defiance itself, then you could leverage some antipsychotics. Risperidol tends to be one that's often used in this case. But short term, again, we, especially for kiddos and teens and stuff, we don't want to be using these long term. You can also use mood stabilizers like Depakote to help with some of that irritability. But these are all off-label uses. These are not medications. Like I said, there aren't any for ODD. So we're just kind of trying to deal with the symptoms. If there is a comorbid like ADHD, then you want to treat that. Oftentimes those are comorbid together, meaning ADHD and ODD, are seen together. And that may be a reason why they're having a lot of this oppositional defiance. So make sure that's ruled out. If the person does have ADHD on top of it, then making sure that that's being treated. Anxiety disorder can also be something that's common. Make sure that's being treated, and depression, of course. So making sure that they were seen by a child psychiatrist, that a psychiatrist who's able to really like differentiate the two, all of the different things, and say that this is just ODD, or it might be ODD and ADHD or something else. And if it is something else, we're treating whatever that something else is. But first and foremost, that they're getting into therapy. Now, when I hear someone with ODD and I think of someone with ODD, I want to make sure I'm ruling out absolutely nutrient deficiencies, because commonly too much copper can cause irritability. Something called cryptopyruria disorder, where you're wasting your zinc and your B6, can also cause that, because now and then copper will be imbalanced to zinc. So looking at that, HPHPA, a bacterial marker that you can test in oats test, or microbial organic acid test. So either an oats or moats that has HPHPA as a biomarker to test, and if that's positive, very significant for causing irritability and some of these other symptoms that accompany these types of disorders. So I would be looking at those kinds of things, if you ask me, with ODD, before jumping into medications to treat that anger, irritability that can go along with it, because it could actually be something completely different. It could be diet, seeing what they're eating. All of those factors need to be looked at. Like I said, we have to treat them as a whole. Emmanuel Aguilar, this 40-oxetine and SSRI, is it also effective for panic disorder? So no, 40-oxetine is a serotonin multimodal antidepressant, not an SSRI, but it has a lot of actions on serotonin, um, along with a lot of other. So it modulates serotonin in many different ways, and in the way that it modulates serotonin, it has downstream effects to affect other neurotransmitters. So it can be very powerful, specifically for depression, because it can modulate norepinephrine and dopamine, even the glutamate system. So can it help with panic disorder? That would not be my first choice for panic disorder because is with vortioxetine, we're also, like I said, we're leveraging the serotonin system and then having downstream effects on norepinephrine and dopamine, which oftentimes with those with severe panic disorder and anxiety are very sensitive to that and oftentimes can make them feel worse. So would not be my first choice for panic disorder, though I have seen patients with anxiety, maybe with panic attacks, like a generalized anxiety disorder with panic attacks, not so much really panic disorder, do well with vortioxetine with anxiety. So sometimes it takes trial and error. Okay. Sejal Patel. Hello. For my son, how 18 student does long-term 1-year use of antipsychotic medicine cause memory and concentration focus issues? Um, so 1-year use of antipsychotic. Yes. Unfortunately, it can lead to some concentration focus issues, brain fog, blunting effect, which is kind of like they just don't really they maybe he's looking a little flat in their expression. If that's happening, then I would say absolutely yes. This is unfortunately a side effect of these antipsychotics. It is blunting their emotional response, blunting their ability to think clearly. Um, so something that you definitely need to discuss with their psychiatrist. And like I said, look into some other reasons why maybe they were put on an antipsychotic, whatever those symptoms were, some other reasons for that, like I had just been mentioning throughout today's live, and look at your mental health labs, for your son. Okay. All right. Pradeep M. After switching from vortioxetine to escitalopram, escitalopram is no more working. Why? Switching from vortioxetine to escitalopram. Okay. I had been on escitalopram on and off multiple times. It never loses effectiveness. Okay. So you went from a serotonin multimodal antidepressant back to an SSRI, escitalopram, and now it's not working. Well, your brain became neuroadapted. So you were 10 years on SSRI, lifted, depression lifted, but emotional numbness, very common with emotional blunting, too much serotonin is increasing. I couldn't off of depression even after reduced doses, tried bupropion, didn't help, vortioxetine, no use. Okay. So when you're down this path, this makes a lot of sense because now 10 years on an SSRI, you've just pretty much blunted unfortunately you're on the path of treatment resistant depression. This is how it happens. Um, So your brain is no longer responding to the increases of serotonin that you're providing it, whether it's from vortioxetine or whether it's from an SSRI or probably any other modulator. If you try bupropion, which is not even on the SSRI, that's dopamine norepinephrine, and it didn't help, um, then I would be looking at other things. I would be looking at TMS, for instance, transcranial magnetic stimulation, non-medication things to help treat this, because it sounds to me like you because you were on it for so long, your brain is kind of like, I'm done. And we need to increase BDNF and increase, these connections a different way than chemically induced. Okay. And that's why I say that these medications are okay for short term when we want to numb some emotions that maybe are too overactive and we want to work on skills, but then we got to come off. When you're on them for 10 years, I mean, it's no wonder that this has happened, and it's unfortunate and very, very common. So what you also want to do when you're at this point, so I would be looking at TMS, but I would also be looking at my nutrients, my diet. Most likely you have some permeability, some leaky gut going on. So I'd be looking at that. I'd be looking at food sensitivities and IgG. KMBO has a really good test that looks at your food sensitivities and your. It also does like a gut barrier panel. So it's looking at your LPS, IgG, and I want to say occludin or zonulin, one of those for their IgG. That's the tight junctions, and so that can tell you if you're having leaky gut and if it's coming from, like, if it's very severe, if it's translocating LPS and not a break in the actual integrity of the lining. So depending on that depends on the treatment you move forward in. But oftentimes, like I said, the SSRIs long-term use, you're creating a lot of inflammation in the gut. So I wouldn't be surprised that that's a factor. And you may also be reacting to a lot of foods and not realize it. So that test could help guide on what we try to eliminate, reduce, and then what we do to bolster your GI system, to help combat that and try to get things back online. Because in doing so, you lower inflammation, you kind of get the enteric nervous system and the vagus nerve and the brain all communicating again and working well in harmony instead of disharmony. So that could be another thing you can do when you're in this state of treatment resistance. And then those labs, those making sure, because when you do have this happen, oftentimes, well, you're not absorbing your nutrients, unfortunately. And so you end up with a lot of nutrient deficiencies or suboptimal nutrient levels. So testing for those and doing not micro, but mental health lab testing. So I have a video on that you could look at to get that done as well. But it seems to me that, what a conventional provider will probably say or do is want to add more medication. And I would say no, because you're going to end up here again in a year or two. So you're just kicking the can. So they would add maybe an antipsychotic would be the next step for that a conventional psychiatrist or psych nurse practitioner would be thinking. But I'm warning you against that because, like I said, you're just kicking the can. And you're going to, in a couple years, usually end up right back to treatment resistant, nothing working, and maybe even making you feel worse. So that's why we need to leverage these other things and try to kind of reverse engineer what just happened in the brain, and try to get your neurotransmitters, all of those transport systems working the way they're meant to work and not being subdued by chemicals, which is what happened, unfortunately, with 10 years of SSRI use. Okay. Diaz, hello. Currently on sertraline 25 milligrams. How do you feel about a mushroom complex like lion's mane, turkey, taki, reishi, cordyceps, mishaki, chaga for ADHD? Okay. Yeah, I do like the mushroom complexes, and I think that they could be very helpful. And if you're only on 25 milligrams of sertraline, don't believe that there's going to be much of a issue with drug interactions here, or maybe stimulating the brain too much where now you're at risk of something like serotonin syndrome. But just run this by your provider, just to make sure that they're on board and they can do their checks and everything to make sure that there's nothing that I could be missing, just kind of thinking off the top of my head here. But yeah, oftentimes you could use adaptogens. That's what these are called, adaptogens and nootropics. When you throw in lion's mane and things like that in here, can be very, very helpful for attention deficit and leveraging that focus and that attention. So yeah, certainly the only thing too, when you're looking at supplements that I haven't mentioned, but should, is that you've got to make sure with any supplement company that you're ordering from, they're third-party tested. They have a certification, like either a CLIA, CLIA. So they're like a third-party lab test has, tested them. And usually when they do that, they're proud about it. They'll have their reports available. Or if the company has like a chat, you could ask them, hey, can I see a copy of your last lab test, third-party test? Can I see a copy of that? They'll be happy to send it to you because it's something they're proud of. It's something that they do to make sure that they can assure you, the consumer, that everything they list in that supplement is what you're getting. Okay. Unfortunately, there are a lot of supplements on the market. These are like your Walmarts, your Walgreens, like just kind of out there on the market, not really vetted well. these are unfortunately like your Nature's Bounty and all these other ones and stuff like that that are not regulated. Okay. And none of these are really regulated by FDA, first of all, but they can choose to be certified by a regulating body like the CLIA. There's others too. I just can't think of what their names are off the top of my head. But so third party testing is the key, and making sure they have those reports available to you, because that means that everything they say on their label is true. Every ingredient that they list and the milligrams they list is true. There's no chemicals added in there that are harmful, that because they'll list all the ingredients in there as well. So there's nothing aside from that kind of mixed in there. And they've been tested for instance, heavy metals and things like that that can get contaminated into supplements. So oftentimes when patients say they are taking supplements, and I find that they're buying them from these non-credible sources and they're feeling worse, it's because of that. So keep that in mind, everyone out there. If you're looking at buying supplements, that you are looking for a company that does third party testing for their supplements. They proudly show those tests and certifications on their website, or when you ask them, they immediately send you their last test. Those are all going to be good things. Full Scripts is a wholesale online store for supplements. You have to be with a provider or someone that is working with you to kind of sign into an account on Full Scripts. They're just on their dispensary, but those all go through. They do. Full Scripts does a lot of the vetting for the consumer and for the provider. So that's what I like to use, is Full Scripts. But there are brands that are outside of Full Scripts that are still good. So when I have someone who's on a bunch of supplements and I'm working with them and they really like them, I just kind of do the back end look and make sure that the supplements and the brands that they're taking, that everything is okay, before asking them to switch. So that's just something as a side note that you should do. But certainly these mushroom complexes can be very beneficial. So that wraps up. That was the last of those 7 questions that we had when I said the time was up, and I was willing to answer those. If there are any more questions here, I will make sure to throw that into the next newsletter. So if you aren't already, you can subscribe to the newsletter, levelheadedmind.com, at the bottom. And I don't spam people. I only do like once a month newsletter. So I'm not like giving you newsletters every other week or anything like that. So just so you know, so we'll be getting one out before the end of September here. Probably I'll finish writing one up today, and then it'll go out next week. So anyhow, make sure you're signed up for that. Lots of information. I share articles from the website and everything that we do. And hopefully you guys have enjoyed this time. Like and subscribe if you're not already. And consider being a member. We do more personal lives. We have a small group of 9 right now. You're welcome to join us. I just sent them a poll to see if they want to start doing Zoom call sessions with me. So if that's something you're interested in, consider becoming a member, because I'll be sending a link to them and we'll start moving forward. If I get enough members that are interested in doing Zoom coaching type calls instead of this live format on YouTube, where you can ask me direct questions, we can work one-on-one, in a time slot together, and as like a group setting. Okay. And that is only $4.99 a month. So you consider being a member. It's very affordable. And that is what I'm offering my members there. And we also do, like I said, these lives. And then if I don't have a lot of questions, then I have topics that I go over, and I'll get your, hey, what topic would you like to go over this week? Because I'll have a couple topics that I'm working on, and I present a topic. So you're getting a lot of information with those videos. They're more of education and learning style videos where, I have PowerPoints and I'm showing you things and helping you to learn. how to manage medication side effects, deprescribing techniques. I've gone over the deprescribing book before, talked about nutrition and mental health very recently, vagus nerve, deep breathing techniques. So lots of information there that you can get on the members site right now that's available to you because those are all recorded. And then moving forward, we're going to be doing some more one-on-ones. So more personal, Zoom, I guess, is more the, instead of, Zoom to Zoom, is more the, I guess, correct term. So consider becoming a member if you're not already. And I'll be seeing you guys next month. We're going to be doing October. So the third week of October, we're looking at October what is it, the 19th? So as long as, yeah, it looks like the 19th, as long as Raul is available. We will make sure that we do that. He says he's available. So October the 19th would be the next live. So the third Saturday of each month, 11 a.m. Eastern Standard Time till 1 p.m. Eastern Standard Time. And today I went till 1:30. So bonus, bonus, bonus. All right. Thank you all. And I'll look forward to seeing you guys next month. Take care.